Axbar warriors, we are honored to introduce our next speaker, a remarkable force in the field of pain management and rehabilitation. With a passion for education, research, and exceptional patient care, Linda Heimstra is a true advocate for those seeking a better life despite chronic pain. Linda embarked on a journey in the world of occupational therapy when she graduated from the University of Stellenbosch in 2002. She didn't stop there. She continued to fuel her passion for helping others by earning 2 postgraduate diplomas, one in vocational rehabilitation and another in interdisciplinary pain management. Her thirst for knowledge has never quenched, as she's currently pursuing a Master's of Science in Clinical Pain Management at the prestigious University of Edinburgh. Linda's career has been a testament to her unwavering commitment to making a difference. She spent 2 transformative years working in the UK before returning to Cape Town in 2005. She later became the Chief OT in the Work Assessment Unit at Groote Schuur Hospital, a role where her dedication to improving the lives of patients shone brightly. In 2010, she took the leap and founded her private practice, an endeavor that has touched the lives of many in the Western Cape. Today, Linda is the Chief Clinical Officer and Lead Clinician at PAIN, an interdisciplinary pain management service in the private sector. She also wears multiple hats as a treasurer of the Occupational Therapy Pain Management Group and a council member of PAIN SA. Her commitment to excellence is reflected in her role as an educator, where she imparts her wisdom to the next generation of professionals. She teaches part-time at UCT on the postgraduate pain management program and regularly presents at courses, workshops, and conferences. Today, Linda will be sharing her expertise on how to manage your pain, a topic of immense importance to our community. Her insights promise to provide a pathway to better pain management and improved quality of life. With great anticipation, let's extend a warm welcome to Linda Heimstra.
Thanks, Matt. That introduction makes me blush. Let me just find my slides. Right. There we go. Are you guys able to see the slides?
Yes, we can.
Right. I'm just going to turn my camera off so that we don't have issues with sound. Right. So talking about pain and what you can do about it. So listening to Dr. Dave preceding this talk, I was just reminded again of how complex the human body is and how little we still understand about it. But I guess the one thing that we all know is pain. Pain is part of the human condition. It's something that everyone experiences. There's a little pocket of people who have a genetic abnormality that makes them insensible to pain, so they can't experience pain at all. But the payoff for that, what might sound like a great benefit, is that they don't live particularly long because they have no warning system. So before we get into what you can do about your pain, it might be helpful to just think about what pain is. And this might sound like a bit of a stupid question. Sorry, my slides are not moving. There we go. Until you actually try and answer with a definition to what pain is. So we know that pain hurts, right? If someone says to you, what is pain? The first thing that might pop into your head is that it just hurts. But the big thing that really is the negative about pain is that it stops you from doing the things that you want to and have to do. It's useful because it can be a warning that something might be wrong, but it's also really annoying, and it's depressing, and it's irritating, and it's scary, and it's distressing, and it's isolating. And I was listening to the video during the break on the mental health impacts of AXPA and thinking that those are impacts of pain, right? It is deeply, deeply unpleasant, and it's not something that anyone else, if you have pain, no one can understand what that feels like. It is deeply personal. And I think Miranda's video was first, and she was saying how this is an invisible disease. And pain is the same. Pain is invisible. I can't tell if I have a room full of people and I look at their faces, I cannot tell who of those people are experiencing pain and who not. And that's why it's so isolating. It is so it's so uniquely human, and it's so uniquely universal, but it is at the same time so uniquely independent and personal. But if we have to define it, so if we have to give a definition to it, and some of you may have heard this definition before, it's the definition from the International Association for the Study of Pain, is that pain is an unpleasant sensory and emotional experience that is associated with actual or potential tissue damage or described in terms of such damage. And I'm just going to unpack that a little bit because that's a mouthful. So pain is unpleasant. We're all in agreement with that. It is always sensory and emotional. So we feel it in our bodies. We can describe what that feels like. We might say that it's dull or aching or sharp or shooting, but it always elicits some form of emotion at the same time. And most of the time, those emotions are negative emotions. So it might be fear or anger or distress or hopelessness or helplessness. So there's some emotional response. It is associated with actual or potential tissue damage. Now, this is where things get a little bit interesting, because you can have pain without having any tissue damage, and you can have tissue damage without having any pain. And the example that I typically use, I quite enjoy cooking. And so sometimes I'm in the kitchen and I'm chopping stuff up and I'm carrying on, and there's a time pressure because the family are arriving any minute for the meal. And I slice into a lemon and suddenly something on my finger burns. And I notice that I've cut myself somewhere along the way. It's bleeding, but it didn't hurt until that point. And so there was tissue damage, right? But there was no pain. But at the same time, you can have a huge amount of tissue damage. So sometimes we will see patients with a scan that looks disastrous, but actually they don't have a huge amount of pain. And then the last part of the definition is that it's also whatever someone describes in terms of such damage. So some of you may have suffered a personal loss at some point, and the words we use, so if you've had a loss or you've had a broken heart, that's what we talk about, right? We speak about having a broken heart. We speak about feeling like our heart is being ripped out of our chest. So all of that is encompassed by this little word called pain. Now, pain is not the same as nociception, and nociception essentially is the message that comes from the tissues that something has happened. At the point where the message starts, the brain doesn't know what has happened, only that something has happened or that something is going on and that it is potentially dangerous. Pain is the alarm or is the siren that the brain then creates in response to that message. And the purpose for which it creates the message, and I'll speak about this a little bit later on, is essentially to ensure your survival. And so it creates this siren, this alarm to change behavior, to make you go to the doctor, to make you change position, to make you ask for help, whatever it is that needs to happen to change your behavior, to reduce the input that's coming in, to reduce the messages, right? And most of the time, what we see as healthcare providers is that people don't come to seek help with a doctor or a therapist because of their pain. They come because the pain is causing suffering. The pain is stopping them from doing what they want to or have to do. And it's causing distress. And so it's actually the suffering that is the problem. The thing that people want to get rid of is the suffering. If you can manage your pain on your own, it doesn't necessarily cause that amount of suffering. If we think about a headache, you have a headache, you take a Panado, it goes away, Bob's your uncle, you're done. You take a headache, you take a Panado, the pain doesn't go away, and you do something else, right? You change your behavior even more. So you might take a Myprodol. And if that doesn't work, then you start worrying and you start thinking, well, now I can't do my job. I can't bath my kids. My headache is just pounding. It's just, I can't see, I can't. And it starts to cause suffering. And it's the suffering that makes you go to the doctor. And what we see as healthcare providers is what you bring to us, right? It's the words, it's the postures, it's the behavior that is communicating that suffering. Now, our bodies have multiple alarm systems, and I'll talk about that in the next slide, but pain is the one that you cannot ignore. It forces you to change your behavior. And I've already said it's like this siren, this alarm. The good thing or the bad thing, depending on where you're at and how much you know, is that the sensitivity of this alarm system can change. And if you think about your house alarm or a car alarm or any other kind of alarm system, if it becomes too sensitive, right? If we take the example of a car alarm, those of you who have cars with alarms, but you might have also been at a shopping center and you're in the parking lot and there's a car and its alarm is going off, but there's no one near it. And the same thing happens with our nervous systems, is that the sensitivity can change and it can become too sensitive and go off for no particular reason that seems to be useful. And different things in our lives can contribute to this alarm system becoming more sensitive or less sensitive. And we'll get to that when we start talking about what you can do about pain. So we have 4 main alarm systems in our bodies, and Dr. Epstein was talking about the immune system and how that causes these gut symptoms. You know that axSpA is an autoimmune condition. But the 4 main alarm systems in our bodies are essentially the central nervous system, the stress system, the sensory system, and the immune system. And they all talk to each other. Their sensitivity constantly is changing and fluctuating, and they influence each other. And this, in all of these systems, is a normal response. It is designed to protect us. So this constant shifting of sensitivity is part of what we call homeostasis. So it's maintaining balance within the body. So the problem is not that the sensitivity can change. The problem is when that volume knob, that sensitivity gets turned all the way up and it gets stuck there. So when the response is no longer helpful, when it's no longer getting you to the point where it is changing your behavior and it resets and it almost goes back to normal. So if the volume gets turned up on one of these systems, it has an impact on the others. But it also means that if one system becomes too sensitive, we might be able to use some of the other systems and reduce the sensitivity on those if one particular system is proving a little bit resistant, and that might help us to turn down the volume on all of the other systems. So what causes the volume knob to get stuck? Now, pain is a funny thing. It's an interesting thing, and one of the things that we've learned over the last kind of 10-15 years. So pain science is actually really quite young in terms of research and development. And what we've learned over the last kind of 10-15 years is that pain is more about threat than it is about tissue damage. So it is about how dangerous your brain thinks that a particular input is to your survival, your integrity as a human. And so what causes the volume knob to shift and then potentially to get stuck can be literally almost anything. But we know that genetics plays a part. We know that there are genetic predispositions to people developing certain conditions and to their bodies responding in a certain way to certain conditions. We know that chronic stress and lifestyle changes, and Dr. Epstein was speaking about that in his talk, that has an influence. Something as simple as an acute infection actually can cause the volume knob to get stuck. And again, Dr. Epstein was talking about gastric infections. But one of the questions that I often ask when someone comes to see me and they are experiencing a flare-up of their pain is whether they've recently had a bladder infection, a cold, a gastric infection, the flu, any kind of acute infection, because that inflammatory response to infection activates the immune system. And as I showed you on the previous slide, the immune system talks to the central nervous system, it talks to the stress system, it talks to the sensory system, and everything can just become a little bit more sensitive in kind of the 2 weeks before and the 2 weeks after an infection. So that's one of the, I guess, tricks maybe to have this mental checklist of going through these things that might be aggravating your pain, and almost then being able to go, okay, I know what this is. I know why my pain is worse, which then makes it a little bit less scary. Trauma, when I'm speaking about trauma, I'm speaking about structural trauma, but also early childhood events, traumatic experiences as an adult. It doesn't really matter. The issue is that the system becomes overwhelmed by the amount of input. And so traumatic events can very easily overwhelm more than one of our alarm systems. Smoking, we know, is a predisposing factor both for onset of chronic conditions, but also for aggravating symptoms of chronic conditions. Sleep is an interesting one. Sleep is considered an independent risk factor for the development of chronic pain. So even if you don't have a medical condition of any kind, and I keep you awake for 3 nights in a row and don't allow you to sleep during the day either, by day 4, you will have pain. So sleep is a really, really critical thing to address when someone is struggling with pain. And it's got this bidirectional relationship, right? So you might have pain and therefore you're not sleeping well, or you might not be sleeping well and then you have more pain. But sleep is sleep contributes to a greater extent than pain does. So sleep contributes to a greater extent to the development and exacerbation of pain than pain does to the development and exacerbation of insomnia. So sleep is really, really important to get sorted out. Then poor diet. You've heard a little bit about dietary stuff in Dr. Epstein's talk, but really the issue around diet is the inflammation and the inflammatory load and how that aggravates pain. Then sedentary lifestyle. I know Lauren is going to be talking to you about exercise a little bit later, but this is not just a lack of exercise. It is being static, and specifically sitting for long periods. Now, I know we're all sitting for most of today. We're talking long-term sedentary lifestyle. And then this concept of this mismatch between load and capacity. So the system's becoming overwhelmed and almost not being able to reset. And that can be a mismatch in terms of physical load. It can be a mismatch in terms of emotional or cognitive load. Really anything can disrupt the balance between load and capacity. And I've given you this list, but really anything else that your brain might interpret as being a threat to your survival. So it might be something like a financial debt. It might be a disruption in relationships that are meaningful to you. So it's often quite difficult to go, it's this thing, it's this one thing. More often than not, it's a combination of different things that get interpreted in the brain as being threatening and being dangerous to survival, which then results in some form of alarm. And it can be fatigue, it can be pain, it can be gastric symptoms. Pain is it's almost the top of the pyramid. It's the one thing that we can't ignore, and that makes us change our behavior, as I've said. So Pain is made in the brain. Now, this is an important concept to understand, because very often I'll see patients and they will have gotten the impression from a healthcare provider somewhere along the line that their pain is all in their head. This is not what this is about, right? This is about how the signals that are coming in from the body and the environment is received and processed in the spinal cord and the brain. So the central nervous system consists of the spinal cord and the brain, and they work together to essentially take information from the body and the environment, process it, make sense of it, and decide how important it is, and then generate a response. And you'll see on the next slide that it's this input-output system. And I'll try and explain it in a way that makes useful sense. So the brain gets nociceptive input, so that is any signal that is potentially dangerous. So those signals that I spoke about earlier, which most of the time are either mechanical, chemical, or thermal. So mechanical, things like pressure, stretch, stiffness, anything that's coming from the skin, the muscles, the ligaments, the joints. Those tend to be mechanical inputs. Thermal, obviously hot or cold, and most of you will know that in cold weather your pain seems to be a little bit worse, but also something that most people will be familiar with, something like sunburn, where the heat has actually made the nerves a little bit too sensitive and they're firing all the time. They're generating a lot of messages going to the brain and going, something has happened and it's not fun. And so the brain then has to decide how important this is to your survival, and it decides whether to make pain or fatigue or gastric symptoms or whatever the siren, the alarm is. The brain can also turn the volume up or down. And one of the examples that seems to resonate with people is to demonstrate this concept that it's about threat rather than it is about damage. If you think about someone who is in a car accident and they maybe break their ankle, but as they hit the lamppost in this car accident, the car bursts into flames. That person is going to get out of the car as quickly as they can and run down the road to get as far away from this car that is about to explode, right? And only once they're safe will the pain in their ankle start. Now, there are lots of chemical reasons for that, but the primary function there is that the brain is going, what is most important right now? What is most important right now is to get away from the fire that is potentially going to kill me. And so it turns the volume down on the pain coming from the ankle fracture and turns the volume up on the message of get out, get away. So that's kind of what I mean by the volume being turned up or down. And it's the volume gets turned up if the brain interprets the messages coming in as being really, really important and possibly really serious and really dangerous. And it turns the volume down if it comes to the conclusion that actually it's not that bad. So you bump your head on the table or on the cupboard as you come up, and you rub the top of your head and you look at your hand and you go, oh, there's no blood, and immediately the volume gets turned down. Whereas if you look at your hand and there is blood, the volume will get turned up. The other important concept about the brain and pain is that there is no single pain center in the brain, which is why there is no single treatment that necessarily can, I guess, eliminate all pain. When scientists have done MRI scans of people with chronic pain, or with pain really, whether acute or chronic, they have noticed on an MRI scan that there are 400 distinct areas of the brain that light up when someone is in pain, which means that your brain is super busy when you experience pain. And that's why it can be difficult to pay attention to stuff, to remember where you've left your car keys, to remember what someone told you while you were experiencing pain, to follow instructions, right? So the brain, when it is in pain, is super busy because it's trying to save your life. And so very often people will say to me that they're really, really worried because they can't remember stuff and they think that they're going mad and they're getting dementia. No, you're not. Your brain is just really busy when you have pain. So this is the current model that we use to understand pain and understand what's going on in pain. And it looks really complicated, and don't panic. I will explain it in a minute. This is called the body self neuromatrix model. And essentially what it demonstrates is that pain is made up of different components. So it's made up of a cognitive component, a sensory component, and an affective component. Now, affective just means emotion. So we have inputs on the left side of your screen. And cognitive inputs are things like, what happened the last time I had pain? What treatments worked? How bad was it then? What diagnosis was I given? What does this all mean? And so memories of past experience, meaning around pain, what does it mean for my job? All of those things are cognitive inputs. Then we have the sensory input. So where is my pain? What does it feel like? Does the joint look red and hot? Is it swollen? All of those sensory inputs that we're getting continuously from the skin, our organs, our muscles, and our joints. And that all of those messages get pushed into the brain. None of this makes sense just yet. Then we have all of the emotions that go alongside with pain. So being scared, being anxious, being angry. Fear is a very significant driver of pain. So all of these inputs come in, they get processed in the brain, and then we have the output. So we have the, what does pain then feel like? What do I feel like emotionally? What am I thinking about all of this? We have behaviors. So if you have pain in your knee, you might start limping. And these are voluntary or involuntary. So you might not even be aware that you're limping, or you might be actively taking less weight onto a joint or a limb to reduce the amount of pain. And then we also have this output into our stress system. So we have a release of cortisol, a whole bunch of other hormones, and we have an immune response as well. So what is the difference between acute and chronic pain? Now, acute pain, I always go, this is the pain that I love as a healthcare provider. I know people don't typically love pain, but acute pain is pain that we understand well. We know what it is. It's useful. It's protective. We can go, it hurts in my left elbow, and it's typically linked to tissue healing time. So we can generally go, well, you know what? I went for a run and I twisted my ankle, and now my ankle hurts and it's swollen and it's blue, and I know what that is. It's usually shorter in duration, but actually we now know that we can't use time as a measure of acuteness. We can't use time to go, well, it's been 2 weeks, so it's now no longer acute pain. But we still do kind of use it to judge tissue healing, because we know that typically soft tissues take 6 weeks to heal and bone takes 3 months to heal. So tissue healing is more important to us than actual time that has passed. Acute pain has predictable behavior. So you take a Panado, it goes away. You put an ice pack on, it goes away. It responds to treatment as you expect. And it's typically a symptom of an injury or disease or a disorder rather than a disease in and of itself. Whereas chronic pain is pain that persists beyond the point where it's useful. It becomes maladaptive. It's no longer something that achieves the aim of helping you survive, helping you exist in the way that you want to and have to. It's no longer linked to tissue damage. It's unpredictable. And as I was saying earlier, it's the suffering, the pain-related disability, and the change in function, the loss of function, that becomes the problem, and not so much what is going on in the tissues. And it can be seen as a disease in itself. Unfortunately, we now, with the advent of the ICD-11, we now have ICD-10 codes, ICD-11 codes for chronic pain conditions specifically. which is helpful from a funding point of view and from a diagnostic point of view. So this is a graph that I find useful to explain things, and something like AXPAR sits in the middle, where you have a lot of peripheral processes going on. So you might have an immune response, you have inflammation, typically you won't have nerve injury, but you also have changes to the system, to how the brain and the spinal cord interprets the messages coming in from the body. And so you can see how this is moving away from time and actually looking at what's happening physiologically, what's happening in the body in terms of the processes that help us understand why someone is presenting with particular complaints. In the world of pain, we speak about 3 different kinds of pain, and I'm not going to go in a huge amount of detail, just to say that typically nociceptive pain is more likely to be acute. So it generally has a history of 6 to 8 weeks. Neuropathic pain is any pain that is caused by an injury or disease of the nervous system. And it's very unique in its characteristics. So patients will complain of burning, shooting, pricking pain, and it does not improve with tissue healing. And then nociplastic pain, typically pain where we can't find the actual, we can't find a specific cause on a scan or on a blood test or anything like that. But then with all 3 of these types of pain, we have what's called nociplastic changes. And essentially what that means is that shift in the sensitivity of the alarm system. So how the messages get interpreted changes on a functional level and on a structural level. One of the important things when we're talking autoimmune conditions and pain is to remember that acute pain is not the same as a flare-up. Now, most of you will be familiar with flare-ups, and really a flare-up is a worsening of the pain that you recognize without a new injury or a new condition. And it's a normal part of persistent pain. And it's about those 4 alarm systems. It's about a change in something in the mix, where the load is exceeding the capacity. Generally, a flare-up is time limited, but it can last weeks, right? So very often patients will say to me, but it's been so long, it can't be a flare-up. Actually, it can be. A flare-up can last anything up to 6 weeks even. Flare-ups can be managed. And this is the point where things also become interesting in terms of what you can do. So when we're talking prospective management, it is about developing a flare-up plan ahead of time before you experience a flare-up with your healthcare provider, and learning as much about your condition as possible, what might cause your flare-ups, what have you experienced before, and packing tools into the toolbox so that when you experience a flare-up that you can manage it effectively. And then retrospectively, when we're talking retrospective management of a flare-up, it's about steps to follow that can help your system settle. Right, so what do we do? What do you do if you have pain? The first thing, and I know that this is an issue for AXPAR, is to get a diagnosis. It's easier said than done, but it's not just about getting a diagnosis of your condition, it is also about getting a pain diagnosis. So becoming informed about your condition and about what the treatment options are that are available, understanding that treating your underlying disease might not also treat your pain. And that's important because you can be on biologics or be on disease-modifying drugs, but still have pain, because it's not the tissue damage, it's not the process necessarily that's going on in the joints or in wherever your pain might be that could be driving it. It can be any of those other factors that increase the sensitivity of the alarm system. So it's a systems error. So educating yourself, movement is always going to be a cornerstone. I spoke a little bit about eating well and sleeping well and managing your stress, and I'll talk about treatment strategies a bit more in a minute, but then finding a team and a support structure that works for you. So you need a team. Dr. Epstein also emphasized this. These conditions are not a single profession treatment approach. With pain, there is no single silver bullet. If there was, I would be a millionaire a few times over. We all want the one thing that is going to fix it. But really, treating pain is about managing it and being an active participant in managing your body and your health. I've already said that treating a disease is not necessarily treating pain, although it could be. And then pain management should be multimodal, and the emphasis should be on self-management, on developing knowledge and skills on what you can do to help yourself when you experience a flare-up, when you have pain. And this slide is very busy. It's really all of the different treatment options that we have for managing pain, and you'll see that I've basically broken it down into 3 categories. So we have medication, we have blocks and stimulators and pumps and things, so interventional things that get done in theatre. And then we have a huge amount of non-pharmacological interventions that really are self-management. Education, exercise, diet, hydration, some mindfulness interventions, things around sleep. Oh, see, I've got mindfulness on here twice. You see, that's how important it is. Some sensory regulation strategies, scheduling activity and learning what to spend energy on and how much energy to spend, and how to work around those load and capacity concepts. There might be specific physical therapies or psychological interventions, and then graded exposure to activities, and hopefully return to work if you are not currently in the workplace. So when you think about managing your disease, also think about what do you have in your toolbox for the management of pain, and who have you made a part of your team for the management of your pain. And if you don't really know, or if you're kind of going, well, just my disease modifying drugs, and your pain is part of the problem, the pain is part of what you're having difficulty with, it might be worth seeing someone who understands pain as much as someone who understands AXSPA. And that, ladies and gentlemen, is that.
Thank you very, very much, Linda, for that amazing presentation. I think sometimes as patients, we don't really see past the pain, and that becomes, it's almost a barrier for us that we just can't see past the pain and dealing with the pain to look into other options that are available to us outside of medication. Thank you very, very much. Appreciate your time and for giving our patients that insight from your expertise. Thank you very much, Linda. Appreciate it.
You're very welcome.